Hi, I'm Dr. Robert Glatter, medical advisor for Medscape Emergency Medicine. Today we'll be discussing the results of a new study published in the Journal of Emergency Medicine looking at the incidence of delayed intracranial hemorrhage among elderly patients taking pre-injury anticoagulants who present to the ED with blunt head trauma. Joining me today is the lead author of the study, Dr. Richard Shih, professor of emergency medicine at Florida Atlantic University. Also joining me is Dr. Christina Shenvi, associate professor of emergency medicine at UNC Chapel Hill with fellowship training in geriatric emergency medicine. Welcome to both of you.
Thanks, Bob.
Thanks. Pleasure to be here.
Yeah, it's a pleasure to have you. Rich, this is a great study, very targeted toward a population we see daily in the emergency department. I want you to, if you can, just describe your methodology, patient selection, how you went about organizing your study to look at this important finding of delayed intracranial hemorrhage, especially in those on coagulants.
This all started for our research team when we first read the 2012 Annals of Emergency Medicine paper. The first author was Mendito, and he looked at a group of patients that had minor head injury that were anticoagulated and had negative initial head CTs. And there was about 100 patients, of which about 10 of them did not consent, but they hospitalized all these patients. So these are anticoagulated, negative first head CT. They hospitalized them and then did a routine second CT at about 24 hours. And they also followed them for a week, and it turned out a little over 7% of them had delayed head CT. We were wondering how many delayed intracranial hemorrhages had we missed, because current practice for us was really that if they had a good physical exam, their head CT was normal and everything looked good, we would send them home. And so because of that, and I think a number of other people across the country wanted to verify those findings from the Mendito study. And so we sat around and tried to design a good study to answer that question. We happen to have a very good population in Florida because there's really a large geriatric population. And our ED census is very high for age over 65. It's nearly 60%. And so we actually included 2 hospitals in this study because there's 2 level 1 trauma centers in Palm Beach County. So we included a second hospital, so it's a multi-center hospital, and we prospectively enrolled patients. And we know the current state of practice is not to routinely do second CTs. So we followed these patients over time, followed their medical records to try to identify these delayed bleeds. And so that's how we set up our methodology.
For the bulk of these patients with a negative head CT, and it's been my practice, that when they're stable and they look fine and there's no other apparent, distracting painful trauma, injuries, and so forth, that they're safe to discharge. The secondary outcome in your study is interesting, the need for neurosurgical intervention in terms of those with delayed ICH.
I do believe that it's certainly not the problem that Mendito described, which is 7%. There are 2 other prospective studies that have looked at this issue with delayed bleed on anticoagulants. Both of these also showed a relatively low rate of delayed bleed, which is between like 0.2 to 1%. Our study was 0.4%. But the differences in the studies is that Mendito, they routinely did 24-hour head CTs. They admitted everybody. These other 3, that routine head CT was not part of it. So my bet is that there is a rate of delayed bleed somewhere in between the Mendito and all the other studies. However, talking about significant intracranial hemorrhage, ones that perhaps need neurosurgery, I believe most of them are not significant. There's some number that do occur, but the vast majority of those probably don't need neurosurgery. We had 14 delayed bleeds out of 6,000 patients with head trauma, and actually one of them ended up having to have neurosurgery. So I think the answer is not zero. I don't think it's 7% either.
Right. Dr. Shenvi, I want to bring you into the conversation, obviously, and really talk about your experience at UNC and how you run things in terms of elderly patients with blunt head trauma on pre-injury anticoagulants.
Yes, thanks, Rob. So I remember when this paper came out showing this 7% rate of delayed bleed. And the question was, well, should we be admitting all these people? And partly just from an overwhelming need for capacity that would bring, it just wasn't practical to say, okay, we're going to admit every patient with a negative head CT to the hospital and rescan them. That would be, hundreds, thousands of patients each year in any given facility. And the other thing is the delayed bleeds don't always happen just in the first 24 hours. So it's not even a matter of bring them into OBS for 24 hours, watch them, rescan them if they have symptoms. It can be several days out. So that never, I think, in almost any institution that I know of, became standard practice. The way that it did change my care was to give good return precautions to patients, to make sure they have somebody with them to say, hey, sometimes you can have a bleed several days out after a fall, even though your scan here today looked perfect. And to alert them to, if they start having severe headaches, vomiting, all these other symptoms of intracranial hemorrhage, that then they should come back. But I don't think it ever became standard practice, and I think for good reason, because that was one study. And then the subsequent studies that Richard mentioned pretty quickly on the heels of that initial one showed a much lower rate of delayed ICH, with the caveats that the methodology was different. And one other big change from that original study and now to Richard's study is just the shift in anticoagulants. Back in the initial study you mentioned, it was all warfarin. And we know from other studies that looking at warfarin versus the DOACs have lower rates of intracranial hemorrhage after a head injury, lower rates of need for neurosurgical intervention, lower rates of discharge to a skilled nursing facility after an intracranial hemorrhage. So across the board, we know that the DOACs tend to do better. It's difficult to compare newer studies because it's a different medication. It did inform my practice to have an awareness of delayed intracranial hemorrhage so that I warn patients more proactively.
I haven't seen a patient on warfarin in years. So I don't know if either of you have, but it's all DOACs now, essentially, more or less, unless there's some other reason. That shift, is quite apparent.
The problem with looking at delayed bleeds for DOACs versus warfarin is the numbers were so low. And I think we had 13. 7 were in the no anticoagulant group. So the numbers are even lower. So it's hard to say. And I just wanted to comment on something that Dr. Shenvi said. I pretty much agree with everything that she said. Anticoagulants and warfarin, that Mendito study has carryover effect. I mean, people group DOACs with warfarin similarly. And so, when a patient's brought in, the first thing they talk about is head trauma. Oh, they're on an anticoagulant or they're not on an anticoagulant. It's so ingrained. I believe that in emergency medicine, maybe we're just pressed for space and time, and we're not as affected by that 24-hour observation. A lot of our surgeons will automatically admit those patients. And in fact, I haven't seen a guideline from the U.S., but there's 2 international guidelines. One's from Austria, that was just in 2019. One's from Scandinavia, that both recommended 24-hour observation if you're on an anticoagulant. So there is a bit of controversy left over with that. Hopefully, as more and more of the information like our study comes out, people will be a little bit more clear about, I just don't think there's a need to routinely admit them. I do want to mention this Mendito study has such a massive impact on everybody. They pointed out one subgroup of theirs, and of course, it's such a small number of patients. They had 7 delayed bleeds, and Christina was correct. I think like 4 or 5 of them were within that 24 hours, and a couple were diagnosed later over the next couple days. But out of those 7, 4 of them, their INRs were greater than 3. And out of those 4 patients, I've heard people talk about this and recommend, okay, that's the subgroup I would admit. And there's a toss-up with what to do with DOAC because it's very hard to tell if there's an issue, is there problems with, their dosing, whatever. We actually recently looked at that. We have a much larger number than the 4, close to 300 patients that were on warfarin. And we looked at patients that had INRs below 3 and above 3, and we didn't show a difference. We still don't believe that warfarin's a big issue with delayed bleeds.
One of the interesting trends related to warfarin, the DOACs versus no anticoagulant, is, like you mentioned, Dr. Shih, the first question out of people's mouths, or the first piece of information EMS gives you when they come in with a patient who's had a head injury, is, are they on blood thinners or not? And yet the paradigm is shifting to say it's not actually the blood thinners themselves that are giving older patients the higher risk of bleeding, it's age and other comorbidities. Certainly, if you're on an anticoagulant and you start to bleed, your prognosis is much worse because the bleeding doesn't stop. But in terms of who has a bleed, there's much less impact of anticoagulation than we used to think. And that, in part, may be due to the change from warfarin to other medications. In part, some of the experts I've talked to who have done the research on this, they've said, well, actually, warfarin was more of a marker for being much older, more frail, because it was primarily prescribed to the old patients who have significant heart disease, AFib, et cetera. So it was more a marker for somebody who is at risk for an intracranial hemorrhage. So there's a lot of changes that have happened in the last 10 years with the medications and also our understanding.
That's a great point. One thing, Rich, I want to ask you about is in terms of your proxy outcome assessment. When you use that at 14 and 60 days with telephone follow-up and then chart review at, I believe, 60 and 90 days, because obviously everyone can't get another head CT, or it's difficult to follow patients up. Did you find that it worked out well in your prospective cohort study in terms of using that as a proxy, so to speak?
I would say to a certain extent. So unfortunately, we don't have access to the patients to come back to follow up all of them. And there was obviously a large number of patients in our study. And the next best thing was that we had dedicated research assistants calling all of them at 14 days and 60 days. And I've certainly read research studies where when they call them, they get 80, 90% follow-up. We certainly did not achieve that. I don't know if people are more inundated with spam phone calls now, or the older people are just afraid of picking up their phone sometimes with all the scams and so forth. And I totally understand. But in all honesty, we only had about a 30, 35% follow-up using that follow-up pathway. And then the proxy pathway was to look at their charts at 60 and 90 days. And also, we looked at the Florida death registry, which is pretty good. And finally, we had both level 1 trauma centers in the county that we were in participating. It's standard practice that if you have an intracranial hemorrhage from a non-level 1 trauma center, you would be transferred to a level 1 trauma center. That's the protocol. I know that's not followed 100% of the time, but that's part of the proxy follow-up. And certainly you could criticize the study for not having closer to 90% actual contact, but that's the best we could do.
No, I think that's admirable. I think, using that paradigm of what you described certainly allows the reader to understand the difficulty in really assessing patients that don't get follow-up head CT, and hardly anyone does, as we know that. To your point of, having both trauma centers in the county, level 1, so that makes it pretty secure. So I think if we were to do a study encompassing a similar type of regional, aspect, it would be similar.
And I think your proxies, to your all credit, that was kind of as good as you can get. You can never get 100% follow-up, but you really looked at all the different avenues by which patients might present, either the death registry, a level 1 center. So well done on that aspect.
In terms of admissions, you admitted a patient, then you hear back this patient should not have been admitted. They had a negative head CT, but you put them in anyway in the sense of a delayed bleed happening or not happening. It's interesting. Maybe the insurers will start looking at this in some capacity. based on your study, that it's so infrequent that you see a delayed bleed that even admitting someone for any reason whatsoever would be, declined. You see that being an issue? In other words, this leading to pattern in terms of the payers?
Certainly, you could interpret it that way, and that would be unfortunate. The delayed bleed is definitely not zero. That's the first thing. But the second thing is, when you're dealing with an older population, having some sense that they're not doing well is an important contributor to trying to fully assess what's going on. So whether or not they have a bleed or whether they're at risk for falling again and then hitting their head and causing a second bleed, making sure they can do the activities of daily life. I think there really should be some room for a physician to kind of, say, they just got here. We don't know them that well. And there's something about it that bothers me about this person, and have the ability to watch them for at least another 24 hours. At least that's how I feel.
In my location, I think it would be difficult to try to admit somebody purely for observation for a delayed bleed. I think we would get a lot of pushback on that. The reason I might admit a patient after a fall with a negative head CT, though, are all the things that, Rob, you alluded to earlier, which is what made them fall in the first place. Or were they unable to get up? I had this happen just this week. A patient who fell couldn't get off the ground for 12 hours. And so now she's dehydrated, delirious with a, slight rhabdo. So then you're admitting them either for the sequelae of the fall that are not related to the ICH, or the fact that they are so debilitated and deconditioned that they cannot take care of themselves. They need physical therapy. And often we will have physical and occupational therapy come see them in the ED during business hours and help make an assessment of, are they safe to go home or will they fall again, to your point? And then that can give more evidence for the need for admission.
Yeah, and just to bring artificial intelligence into this discussion, these algorithms that are out here that say, push a button and, the patient's safe for discharge. Well, this argues for, a clinical gestalt and a human being to make an assessment. Because, you can use these predictive models, which are really coming and they're going to be here soon, and they already are in some sense. But again, I think that here we are, we have to use clinical judgment, human judgment. Yeah.
I agree.
What are your return precautions you discuss with patients who've had blunt head trauma, that maybe had a head CT or even didn't? What are the main things we're looking for?
Sure. So what I usually tell people is if you start to have a worse headache, start to have nausea or vomiting, or any weakness in one area of your body or vision changes, and if there's a family member or friend there, I'll say, hey, if you notice that they're acting differently or seem confused, come back.
I agree with what she said, and I'm also going to add one thing. The most important part, I think, is they trying to prevent a subsequent fall. And so we know that when they've fallen and they present to the ED, they're at even higher risk for falling and re-injuring themselves. And that's a population that's already at risk. One of the secondary studies that we published out of this project was looking at follow-up with their primary care physicians. And there were two things that we wanted to address. The first was, how often did they do it? And then when they did do it, did their primary care physicians try to address and prevent subsequent fall? Both the answers are actually bad. Amazingly, just over 60% followed up. And in some of our subsequent research, because we're in the midst of a randomized controlled trial where we do a home visit. And so when we initially see these individuals that have fallen, they'll schedule a home visit for us. And then a week or two later, when we schedule the home visit, many of them cancel because they think, oh, that was a one-off and it's not going to happen again. So part of the problem is the patients, because many of them just believe that they slipped and fell and it's not going to happen again, or they're not prone to it. And then the second question was, when they did go to a primary care physician, we have found that some primary care physicians believe that falling and injuring themselves is just part of the normal aging process. And a percentage of them, they don't go over assessment for fall risk or even initiate fall prevention treatments or programs. I try to take that time to tell them that this is very common in their age group. And believe it or not, a fall from standing is the way people really injure themselves. And there may be ways to prevent subsequent falls and injuries.
Absolutely. Do you find that it's their medicines that they're on often that are a contributor in some sense, either antihypertensive, issues of orthostasis, a new medication added in the last week?
It's all of the above. Sometimes one thing, like, oh, they just started this tamsulosin for their kidney stone. They stood up, they felt lightheaded, they fell. But usually it's multifactorial with some changes in their gait, changes in vision, balance, reflex time, strength, and then plus the medications, the need for assistive devices. Maybe they can't take care of their home as well as they used to, and there's things on the floor. So it's really all of the above.
Would either of you like to add any additional points to the discussion, or maybe just summarize maybe a few pearls?
This just highlights the challenge of how it's harder to unlearn something than to learn it. Where one study that maybe wasn't quite looking at what we needed to, or practice patterns, prescribing patterns have changed, so it's no longer really relevant. But the things that we learned from that, or the fears that we instilled in our minds of, they could go home and have a delayed bleed, those are much harder to unlearn. And it takes more studies to unlearn that idea than it did to actually put it into place. So I'm glad that your team has done this much larger prospective study and hopefully reduced the concern about this entity.
Oh, no, I appreciate that segue. And the only thing I would add is, it is amazing that the paramedics and medical students, the first thing out of their mouth is, are they on an anticoagulant? So in terms of the risk of developing an ICH, I think it's much less than the weight we've put on it before. However, I believe if they have a bleed, the bleeds are worse. So it's kind of a double-edged sword. It's still an important factor. It doesn't come with all the oh my gosh, they're on an anticoagulant that everybody thinks about.
These are obviously ground level falls in the majority and not motor vehicle crashes. And that's an important part, in the population that you looked at, that should be mentioned clearly.
It's astonishing. And I've been a program director for over 20 years, and a lot of geriatrics is not really that well taught in the curriculum, and it's astonishing for a lot of our trainees and just emergency physicians in general that the number one cause for traumatic injury is a fall from standing. And certainly, we get patients come in the trauma center that's like a 95-year-old person who's on a ladder putting up his Christmas lights, and I'm like, oh my God. The vast majority of these. It's closer to 90%, but in our study for the patients we looked at, it was 80%. It's fall from standing. That's the mechanism that causes these bleeds, causes these major injuries.
And that's reflective of what we see. So it's good that that's what you looked at also.
Absolutely. Well, thank you both. This has been a very informative discussion. Appreciate your time, and our readers will certainly benefit from your knowledge and expertise. Thank you again.
Thank you.
Thanks for having me, Bob.
Thanks again.